Morning, everyone. I must say I feel a bit underqualified to be delivering a speech to such an audience with such a vast knowledge. I've only started in the program at the beginning of the year. I've learned a lot. It's strange, at medical school, postgraduate studies, you never learn about substance use or how to manage it. It's always the archaic way of doing things. 10 years of studying, and I think I've learned more in these last 9 months than in those years. Okay, so how was OST implemented in COSAP? As Lorinda said, in the beginning, we didn't have any OST. It started quite small, and then it went on. Why I put maintenance therapy there, it's important because if we look at our essential drug list, the list or the way that we do things in the government setting, in the public health setting, we use this list to determine how we manage patients. Opioid substitution therapy is not on the list as maintenance therapy. It's used for detoxification, inpatient management. So that really makes it different, the way we're doing things. We use directly observed therapy, and it's outpatient-based. We use both methadone and Suboxone. How did we figure out how to do things? So we consulted people, Mr. Sean Shelley. I think he was our main advisor and consultant in how to approach this. We used the SAMS guidelines, and then we developed our own protocols. All of our clinical staff underwent training on methadone and Suboxone, and we also had refresher sessions thereafter. Because we were dealing with a substance and in a field where we didn't know much about how to manage people with the risk of clients overdosing, all our staff underwent basic life support training, which was provided by the University of Pretoria, and our clinical staff was also given refresher courses on how to administer naloxone if need be. All our sites are kitted with emergency kits as well in the event of an emergency. We also have twice monthly team meetings to share all of our experiences and learn ways of improving the management of our clients. At these meetings, it's not just clinical staff, peer educators also join us, and this helps us share experiences. So, what were the processes in implementing OST? Now, legally and according to regulations, if I, as a medical doctor, gave you a prescription, you could take that prescription to the pharmacy, fill it, get your 30-day supply, and then take your medication at home as prescribed, and then I don't see you again for 30 days. Now, what is the problem with this? I don't see you for 30 days. I don't know what's happening in 30 days. What if your dose needs adjusting? And there's no other support offered. So I don't know what's happening in those 30 days. And this is a problem that we've seen because there have been private doctors who have been prescribing drugs, and so it puts a bad light on opioid substitution therapy as well. I'll discuss that as part of the challenges. So why are we different? What have we done? So we follow a more conservative approach. We have on-site team members who work. We have a social worker, a clinical associate. For those of you who don't know, a clinical associate is, I think in the States they call them physician assistants, but they're that equivalent. We have peer educators and we have community health workers. So it's a whole team approach. And then there's a doctor who oversees a few sites. So the client comes to the site, he's seen by a peer educator or a social worker, a community health worker. An assist is done, then a social worker will evaluate the client, and then a medical review will be done by the clinical associate. Where possible, we try and include family members as part of the process, because it's important for clients to also they're still living at home, a lot of them, so their families need to be a part of the process and understand what's happening as well. It's not always possible, especially for clients in the inner city and those who are homeless, who don't have family support. But where possible, we do try and integrate family members. So once the decision to begin OST is jointly made, it's not a paternalistic biomedical approach where we tell people what they need. So this is why it's not just they walk in and they get OST. It's a joint decision. They need to understand. And I think the biggest thing that people need to understand about OST is that it's not a cure. People think it's a cure, it's going to fix me. This is going to fix me from using substances. So that's why there's a lot of education, there's a lot of learning, there's a lot of discussion that goes about before anyone is started on opioid substitution therapy. So once the agreement is made, once there's clarity, once everybody is happy with the decision, we do a confirmatory urine toxicology for opioids. Now, this was quite contentious initially, but what we realized, like Prof. and Anslu were talking about Nyaupe, so it is generally heroin, but because it's not regulated as we've been discussed, you don't know what you're getting. So a lot of clients would come to us and tell us, no, he's smoking Nyaupe and he needs help. But then if you do the urine tox, it's negative for opioids. So does that make sense? No. They don't actually always know what they're getting. And so that's why we decided it was important for us to include the urine toxicology, just to confirm that the substance that they're using is indeed opioids. Then once that is done, we do an OST readiness form. This is just for us to do sort of like a checklist, just to make sure everything is done, there are no contraindications, and the client understands what they're doing. The consent form is signed, and then they're evaluated by the site medical doctor. So we've got 4 medical doctors for our sites. They're obviously not full-time, but they do rotate between the sites. And the doctor will do a medical review, assessment of safety, and also not decide, I should say, but negotiate which form of OST they're going to use, either methadone or Suboxone. This is then discussed with the client and with the family if the client chooses to do it that way. Okay, so what happens next? So as Lorinda said, we allocated budget. So when we first started though, our clients were funding the medication themselves. So clients or family members were assisting to fund the medication. Now, I don't know, I'm sure you know, I'm preaching to the choir, but a 500 ml bottle of methadone costs 850 Rand, which is a lot. So to ask people to buy that is quite a tall order. Most people are surviving on government pension funds, grandmothers' pension funds, children's child support grants, so it's obviously not an easy feat. So if the client is able to afford the medication, we give the prescription to the family member, they collect the medication, and then they bring it back to our site where it was kept by the site, and then the clients were dotted directly from the site. If the client cannot afford OST, then we motivated for funding. So a financial social evaluation was conducted, and then motivation is sent through and we assist them for funding. As Lorinda said initially, it was started off as a 6-month funding and then we would review. Okay, so methadone. We started with initial dose of 5 to 15 mils per day for the first 3 days. And then we also, as we went on, we obviously learned. We've learned a lot, and we've obviously learned that our people who inject drugs need higher initiation doses. Then the client comes in daily for dotting and review of symptoms. Now the daily dotting is obviously the ideal. People are working though, so they can't always come in. So we tailor each person's life to, we would tailor the treatment for each person's lifestyle. And then the clinician, when I say clinician, it's not necessarily a doctor. Our clinical associates do a lot of clinical work. They together with the patient, would discuss increasing the dosages, and then it would be discussed with the doctor at a later stage. Speaking to many people here, and also speaking to Sean, I see Sean is gone, we realized that our doses are quite low compared to the recommended doses of 50 to 120 milligrams. And this is something that we've been discussing amongst ourselves as well. Why are our doses so low? What's going on? What are we doing? Are we doing something wrong? Are we doing something right? Why is it low? So this is something that I'll discuss in the challenges and in the future plan, but it was really something that we had to think about. What are we doing differently that's causing this effect? I'm not going to go into Suboxone. We don't have many clients on Suboxone. I'll discuss the stats. Most of our clients are on methadone, but the way we titrate the medication is according to the package inside as well. I don't know what the recommended, or if we lower on the Suboxone doses, because I don't think there's been much, I don't know, I stand to be corrected, if there's much information on the recommended or the dose of Suboxone. There probably is. Okay, so how do we monitor and maintain our clients? Once they're initiated, we monitor them daily where possible for the first 2 weeks. We dot on site. Then we assess whether a dosage adjustment is needed. And maintenance is determined on an individual basis. Clients are then given decants of exact amounts of OST for the weekends and for periods of travel or work. And we just adjust it according to what they need. So the challenges. Earlier I discussed that OST is not on the essential drug list for maintenance purposes. According to the EDL, it cannot be used for more than 14 days in a state hospital. And if clients are admitted in a hospital and started on OST, they are not given any take-home medication. So they're just discharged, gone back into the world. So there was a lot of difficulty in acceptance of the role of OST by stakeholders, because it's not on the EDL, it's not in the guideline that we use to manage our patients, which is, I would like to say, the EDL is sort of the Bible on medicine of how we treat our patients in the state. So using the EDL versus using the SAMS guidelines, where the SAMS guidelines doesn't really have an endpoint to say you will stop after 6 months, or it's like a guideline, 18 months, see how it goes. Whereas the EDL gives you a detox period of 14 days of how you taper down, which doesn't work. Another challenge was our 6-month OST program, which was done for budgetary constraints, but very soon we realized clients relapsed after 6 months. Some of our clients were self-funding, and a lot of them defaulted their medication due to the cost. Then we had issues where medication was diverted, especially over long weekends or weekends where large amounts of OST was given to them. We also dealt with a lot of polysubstance users. So where the OST would be used, then the heroin use would decrease, but then other substance use would increase. So it was difficult for us to manage that, and more than manage it, know how to manage. What is the right thing to do? I learned about harm reduction for stimulant use yesterday, so that is definitely something we should look at and incorporate into our program. So clients that came in to our sites, ideally, we would have liked to provide a comprehensive care package, an all-inclusive service. But as Lorinda had mentioned, not all of our sites were set at ideal clinic sites. We sort of used what we had. So in many of our sites, we didn't have other health facilities available, primary healthcare facilities. So where we could do an HIV test, we couldn't start treatment. Or where we could do a screening for TB, but we couldn't test for TB. So a lot of our clients had to be referred to local health services, which is easy enough, except that there's a lot of stigma still at the local health services. There's long queues. I know everybody stands in queues, but it's obviously not fun if you're withdrawing or if you're not feeling well. And people are standing in queues and they know who's a user, who's not a user. So that was a huge deterrent, and we found that our clients were not going. They were ill, but they were still not accessing the healthcare system. I spoke earlier about our dosing being a bit low, and the big thing that we thought about was whether we have actually established a trusting clinician-client relationship where the client can express to us that they need to increase their dose. Because it's not that the doses were low because I hope we were not the barrier to increasing the dose, but if you ask your client, are you okay? Do we need to go up? They would say no. Are you sure? Yes, I'm sure. I don't need to go up. And then you find out peers would tell us, no, but the client is topping up. There's something going on here. So why were they not feeling that they could trust us enough to tell us? Is it a cost thing? Obviously, if you need more medication, it'll cost more. But then this was happening with those who we were funding as well. Do they feel that they're disappointing us by going higher in doses? Why are they not going up? Why do they feel that they need to stay at a low dose? Then we also discussed where family members were putting pressure on clients, that the more you need, the more you're going to take longer to get off it. The idea is always, when are you getting off this? How long do you need to take this for? Why can't you just take it and then stop? Oh no, you're fine now. So those were some of the issues that we've realized later on as we've gone on. And now I think we need to sit down and see how we're going to manage that. So part of that was the misconception of how OST works. So as much as we said this is not a cure, it's managing, people still thought this is a cure. This is going to fix my child. This is going to, it's going to be a magical cure. And it's strange that no matter how much we said, it's also what goes around in the community, what people think they know and what they spread. So the other challenge that we had was that there were private doctors in the communities prescribing OST incorrectly, not tapering doses, not increasing, just giving them what they thought, 1 teaspoon here, 1 teaspoon there, and you're fine. Take it for 3 days and you'll be okay. So there was a notion that it doesn't work. Oh no, I've used this before and it doesn't work. Then you sit with them and you say, okay, but how did you use it? What was the method that the doctor gave it to you? Then you realize it's completely off. And when you explain to clients and their families, this is how you do it, how we do it, then you do see, oh, okay, and a little bit of understanding. But as soon as you say, look, this is a long-term thing, then you see they sort of feel a bit deflated. Now I have to drink this medication for how much longer? Another challenge that we had was theft and security. But let's be honest, we live in SA. There's always theft and security challenges, even in our homes. Okay, so our plans for improvement. So the big thing was to integrate primary healthcare services at all sites, which would include ARV and TB treatment, primary healthcare services, so that we're not referring to other places. I had a doctor who I worked with in a previous hospital who used to say, all of us are like Dr. Hugo. Dr. You go here, you go here, you go here, and you go here. It was so we want to stop being Dr. Hugo, and we'd like to integrate our services where we're working. Then, as Lorinda mentioned, we're trying to upgrade all of our facilities to meet the ideal clinic standards. And then also to provide a linkage between the hospitals and COSUP so that clients don't get lost. Because they are started, so it's going to take a while for people to catch on to the idea that it's maintenance, not detox. But in the meantime, while that's happening, if they're in hospital, then we'd like to create a linkage for them to send people, sort of like a TB focal point, but a focal point of OST. So send them to a point, let us see them, get their medication, see where they stay, and then we can refer them to the appropriate COSUP site nearest to where they are staying. Our newest site is at a hospital in Tshwane district, so it's within the hospital premises, and we're working quite well with the hospital staff there and the doctors there so that they're aware of us, so they can send their clients to us. And then, of course, to improve, we need to talk about including methadone maintenance treatment in the EDL, which I think is going to be instrumental in treatment, assist more clients with funding, and then also we'd like to improve our storage and control of OST on site. And importantly is to educate the communities on harm reduction as a whole, People, it's amazing, and I always think of when we started with treatment of HIV and giving out condoms. Oh my goodness, you're giving out condoms, people are going to have sex. And now the same thing with NSP. Oh, you're encouraging them to use drugs. It's still that mindset, and it's going to take a lot of conversation and a lot of talking and emphasizing and explaining to get that point across. But we will get there. Community dialogue is important. I think people fear what they don't know, and if you sit and explain and talk, people do understand and they do see the bigger picture. Okay, so Lorinda did mention our stats, but I'll just a little bit more. We've started 892 clients on opioid substitution therapy. 804 of those are on methadone. Suboxone clients are only 88. We're funding 566 of the 892 clients. Retention is always difficult to assess because we knew we weren't really sure. And initially we had started with the 6-month program. So we thought, okay, 6 months is a good start to see how many are retained. But then we found that it's a little bit more complicated than that. We have clients who are incarcerated. Then what happens to them? They drop off, but they haven't really defaulted. Or we have clients who have demised, unfortunately. How do we count those clients? Or we have clients who've moved away. And some clients still decide that they want to start treatment, but then they still want to access rehabilitation services. So it was difficult. In the end, after taking everything into consideration, we do see our retention at about 57%. It fluctuates month to month, so around 60%, I would say. Interestingly enough, you know, I myself, when I came into the program, I thought if I'm paying for it myself, I'm more likely to stay on it because, you know, it's my money. But no, we found that those who are funded by the project are more likely to be retained than those that are funding it themselves. All right, thank you.